Okay, we're going to talk about BPH, which is benign prostatic hyperplasia. In your med-surg text, page 1307 to 14, and it starts off, it identifies risk factors. They're not exactly sure why some men experience BPH and others don't, but certain risk factors include age, family history, race, with African Americans experiencing the highest incident of BPH, and a diet that is high in meats and fats. This picture shows a normal prostate versus one that's become enlarged. For a male to develop BPH, a couple of things have to be in place. Typically, greater than 48 years of age and the presence of testes. We know that prostate growth is regulated or encouraged by the presence of DHT, and DHT is formed in the prostate from testosterone. And while we know that aging men have decreased levels of DHT, it appears that their prostate tissue actually becomes more sensitive to it, therefore encouraging the growth or the enlarged prostate. What you can see here is the main issue is the obstruction or the pressure or constriction that's placed upon the urethra, then leading to the actual signs and symptoms of BPH. In your book, it actually breaks up the signs and symptoms into what we considered irritative symptoms versus obstructive symptoms. And so these are the two different classes of symptoms, but there's interruption, or they have a difficult time maintaining urinary stream. There's hesitation before beginning to urinate, frequency at night, feeling like the bladder is full. There can be dribbling, a sudden urgent need to urinate, and not a very strong stream. These are some of the signs and symptoms. On page 1309 in your book, there are questions that one could ask regarding the significance or the severity of the signs and symptoms of BPH. In order to diagnose, a couple different things. One, a physical exam. We're going to do, or a advanced practitioner, healthcare practitioner is going to do a digital rectal exam. Typically what you find is an enlarged prostate. It's asymmetrical, and then based upon the signs and symptoms the male has experienced, there are different types of tests that can be done. One, let's check a creatinine. We need to know that there's no kidney damage. Let's check a urine. We need to make sure there's not a UTI. You want to go ahead and check a PSA to make sure that we are dealing with BPH and not some type of cancer. A lot of times they will actually do a cystoscopy. If you guys look at page 1308, there's a great picture. It's showing you picture A is a normal picture of what the urethra should look like, and then one that's actually being constricted because of the enlarged prostate. Check a post-residual urine. Greater than 100 is considered high. And a lot of times they will actually do urine flow meters and check the stream. How strong is the stream? If it measures greater than 14 mLs a second, that's considered a strong stream. And if it measures less than 10 mLs a second, that's considered an obstruction or a weak stream. Okay, so a couple of things. We're looking at typically going with medication therapy first. When you're thinking about medication therapy, you got to think about a couple of things. You have to make sure that the enlarged tissue is actually androgen dependent, and that we have an issue with smooth muscle contraction, and take it from there. When we have enlarged prostate tissue, a lot of times the androgen inhibitors, which are called the 5-alpha reductase inhibitors, are prescribed. They help shrink the prostate. Boards is changing. Only generic Names are going to be provided, so that's why I have written in the generic names. So what we have here is finasteride, which is Proscar, and dutasteride, which is the Avodart. So we will go by the generics. The generics is what will be on your test, guys. So they stop the conversion of testosterone to the DHT, and take a significant amount of time to actually work, so up to 6 to 12 months. And so that's something that's very important for your patients to understand. These drugs can cause orthostatic hypotension, so encourage your patient to change position slowly. We need to warn the patient about they could cause impotence, decrease the libido, decrease the amount of ejaculate. The drug can be absorbed through the skin, so we need to be cautious when utilizing it around pregnant women. I'm going to bring in a picture like I did before and just show you the drug card that I have on this particular drug. And you can see some of the other things. I think most of these we have gone over. We've already talked about women who are pregnant and avoiding the exposure to the semen. We already, I think, talked about the majority of these things. Just remember about the significant birth defects. All right, your alpha adrenergic antagonist will actually block the smooth muscle contraction, and this helps relieve obstruction and increase the urine flow. These guys are alpha blockers, and so they're going to result in a lowered blood pressure. So once again, encourage your patient to change position slowly, monitor for orthostatic hypotension. What you guys are going to learn is that the alpha blockers actually end in sin. And so that would be key to know, because the generic for Cardura is the doxazosin. The generic for Flomax is the tamsulosin. And so you want to look for those last words, sin. If you guys haven't figured out by now, I have a puppy who loves to bark. Other things that we need to keep in mind when someone is on an alpha adrenergic antagonist is that they need to take the medicine as prescribed. While they're getting used to the medication, they might want to avoid driving in activities that require alertness until they know how their blood pressure is going to respond. Avoid drinking alcohol. That could always worsen the orthostatic hypotension. We also are going to want to follow them or encourage them to follow up with their healthcare providers to see if not just the alpha adrenergic are working, but the androgen inhibitors are working. You know, are there signs and symptoms of the BPH getting better? Medications do not work for some guys, and so they end up having to have minimal invasive surgeries. Neither one of these cause impotence or incontinence. They don't cure it. They just reduce the size of the prostate and help relieve some of the obstructive signs and symptoms. Typically are done on an outpatient basis. And so when we're doing the transurethral microwave thermotherapy, heat is used to destroy the excess prostate tissue. During this procedure, though, a cooling system protects the urinary tract. And so it takes about an hour, and typically they can go home. When we do a tuna or a transurethral needle ablation therapy, then 2 different needles are used. And once again, low radio frequency is used to burn away a portion of the enlarged prostate. And this, too, should help improve urinary flow. A lot of times the minimally invasive surgery is not effective, and so we step it up, and we have what we call transurethral surgery. So transurethral resection of the prostate is a surgical procedure. Still, no external incisions are made. We actually use a wire loop. The wire loop is used to cut away pieces of the excess enlarged prostate, and then heat is used to cauterize. We've got to flush continuously. We've got to remove this excess tissue that's been burned away from the bladder. And typically this continues post-operatively in the way of a 3-way catheter with bladder irrigation. There are complications associated with having a TURP, and some of those can include bleeding, and then we can have clots after the surgery, an inability to void, maybe a UTI. This also can be associated with incontinence, impotence, and what we call a retrograde ejaculation. And so post-op, these guys typically stay in the hospital, have a 3-way Foley with continuous bladder irrigation going to make sure that all the excess tissue that has been burned away is flushed out. A second way to do a transurethral resection is what we call a TUVP, and this is using vaporization. And so they're burning smaller sections of tissue at a time. It doesn't use excessive heat, and therefore it has a decreased amount of bleeding post-op, how long the catheter has to stay, and then how long the individual has to stay in the hospital. This is typically used for smaller prostates. Someone who has a TURP or TUVP a lot of times comes out with what we call a 3-way catheter. It's just like the catheter you guys learned about the Foleys in lab, except for it has a third port in which you can connect fluid. And so this fluid is connected into the Foley, and then you control it with this clamp, and it flows into the bladder, cleanses the bladder, then drains into a Foley bag. But we have to make sure what goes in comes out, because, like I said, clots are not uncommon post-operatively for these procedures. A clot could occlude the catheter, and then the fluid is being retained in the bladder. And so we want to assess the continuous bladder irrigation, the drainage. What color is it? We would like for it to be a light pink to pink. Are there clots? A lot of times the patients have bladder spasms. They're going to require some kind of medication to relieve the bladder spasms. When we talk about traction, we're talking about on the Foley catheter itself, where the physician might actually take the catheter, pull it tautly, and then secure it with tape. Some of the issues that could happen when someone has a CBI, continuous bladder irrigation, is that they can develop fluid volume excess. These fluids that are going into the bladder are high in sodium, and so we want to make sure that this patient does not experience hypernatremia. Also, in rare cases, the male patient might have to have his prostate removed, have what we call a prostatectomy. We're not going to talk about that here. We'll talk about that when we talk about prostate cancer, but the care would essentially be the same. Some of your nursing diagnoses, and there are many for BPH, just depends on what's a priority to your patient. Could be altered urinary elimination, certainly alteration in comfort, urinary incontinence, disturbed sleep pattern, altered self-image, risk for infection, and risk for injury. So what are some of the things that we need to do for health promotion, for BPH? Well, let's get guys in, encourage them to have their digital rectal exams at the age of 50. We want to educate guys to avoid substances or drinks, things that actually stimulate voiding, such as alcohol and caffeine, and when are they taking their diuretics. We want to teach these men to avoid drugs that have anticholinergic effects. Anticholinergics, remember, increase urinary retention. And so we want to make sure that they understand that they need to watch taking over-the-counter decongestant medications or prescription medications that might aggravate their signs and symptoms. We want to encourage them to empty their bladder every 2 to 3 hours or when the urge first hits, and that they need to try and maintain normal fluid intake, but to avoid intaking large amount of fluids at one time. You can also teach them what we call the double voiding technique. Urinate, and then sit on the toilet for 3 to 5 minutes, then urinate again. And this might help relieve some of the urinary retention. Preoperatively, if these individuals are going to go for some type of pre-op or some type of procedure, we might need to cath them. We might need to check for residual. Remember that we'd like for it to be less than 100, using the Coude method if necessary. Encourage them to void, as we said, when the urge hits them, drinking large amounts of liquid at one time. Talk to them about their medications and knowing that they might get a pre-op antibiotic if they're going to have surgery. We've talked about a lot of this, but post-operatively, adequate eyes and nose, watching for bleeding, watching for clots if they have a Foley catheter, monitoring their vital signs, being aware that they're at risk for bleeding, therefore they're at risk for hypovolemia. Do cath care per hospital policy. Most of the time it's with soap and water every shift, making sure that the catheter is secured, that it's patent, monitoring for bladder spasms, monitoring for urinary tract infections, and keeping traction on the catheter as ordered by the physician. Once again, traction would be where we would take the catheter, or the physician, healthcare provider would take the catheter, apply pressure, pull on it, and then secure it in place. Okay, so for ambulatory care, we want to, if the patient goes home with an indwelling catheter, we want to make sure that they understand how to clean the catheter insertion site every day. We also want to make sure that they understand how to empty the catheter bag, and if they can, how to change between a leg bag and a Foley catheter bag. Often they will wear a leg bag during the daytime, which is more convenient and can be concealed under clothing, but then so they can have drainage at night, they will return it to a Foley bag. If they are experiencing urinary incontinence, especially once the Foley is removed, then they need to be taught how to do Kegel exercises. So just make sure you brush up on how to instruct on Kegel exercises. We want them to know that it can take up to a couple of months for the bladder to return to its normal capacity, to not get discouraged, to go ahead and try and drink 2 to 3 liters of fluid a day, and to go ahead and urinate every 2 to 3 hours to flush the urinary tract system. Watch for signs of infection, the typical signs you would get with a bladder infection, but also a systemic infection. We want them to make sure that they're drinking their fluids, getting plenty of fiber in their diet, or possibly taking some type of fiber to prevent constipation. Could be some changes in sexual function. They could be temporary versus permanent. Sometimes guys, after they have surgery, as we talked about, can experience what we call a retrograde ejaculation, and where the semen is actually discharged into the bladder. And then we need to let them know, if this is the case, it can produce a cloudy urine after they urinate, after having a sexual encounter. If they are experiencing erectile dysfunction, then they need to talk to their urologist or surgeon about this, so they can be considered for possible medication therapy, and to also be checked to see if it's going to be temporary or permanent. Okay, we're going to move on to prostate cancer, and this is in your book, mainly starting on page 1315. It is the most common type of cancer in men, second leading cause of cancer death in the United States. If it is found early, it is very curable. The majority of prostate cancer are adenocarcinomas. Risk factors, obviously age. As one ages, I think the median age is in the later 60s. A positive family history does increase your likelihood of having prostate cancer a little. A vasectomy, a diet that's high in fat and red meats, and certainly race. If you look on the bottom of page 1315, it talks to us about the fact that African American men have the highest incidence of prostate cancer in the United States, that they are often diagnosed at an earlier age and have a more advanced disease, and have a higher mortality rate than white men do. Unfortunately, early signs of prostate cancer usually cause no symptoms. And so if they do, a lot of times the symptoms are very similar to those to BPH, which we just talked about. And so that's why when someone presents with signs and symptoms of BPH, the dysuria, the hesitancy, the dribbling, etc., we make sure that they are worked up not just for BPH, but to also rule out prostate cancer. They could have blood in the urine. It causes no pain, or actually blood in their semen. It could be that they are going to get a physical exam and they have an abnormal DRE. Systemic signs and symptoms, though, could include fatigue, unexplained weight loss, and one of the first places prostate cancer tends to metastasize is bone, and so sometimes they show up with bone pain, especially in the back and the legs, because it has invaded the spinal cord. So when to screen, when not to screen for prostate cancer. A little bit of controversy here, but if you have risk factors such as African American or positive family history, a lot of times they do suggest that you get your PSA checked around 40 to 45. Otherwise, it's typically over the age of 50 that you would have a PSA checked. Just remembering that a PSA is not a confirmation of prostate cancer. There are certain conditions, certain things that happen that cause the PSA levels to be elevated, and so some of those can include just the fact that you're aging, that you have BPH, you've had a recent ejaculation, you have prostatitis, you have an indwelling catheter. So those types of questions have to be asked. A normal PSA is about 0 to 0.4 NGs per ml, and so above that, then we have to be concerned. Also, a digital rectal exam. A digital rectal exam needs to be done, and what we'll feel is a gland that is nodular and fixed. There, you can feel an abnormality. So if someone is suspected, then we need to go ahead. They have to have what we call a transrectal ultrasound, where the physician can get a good look at the actual prostate, pinpoint any abnormalities, and then take a tissue biopsy. The only definite way to diagnose prostate cancer is with a tissue biopsy. If it comes back positive, then we have to determine, or the physician needs to stage it. And so a lot of times they'll have a bone scan, an MRI, a CAT scan, just mainly to determine what is the stage of the cancer and what is the best treatment. Often prostate cancers are slow growing and might not even need treatment. Your book actually says that many men die with prostate cancer, but it is not what has caused their death. So slow-growing prostate cancers sometimes do not require treatment, only those that are aggressive. One surgical option is a radical prostatectomy, where the physician will actually remove the entire prostate, the seminal vesicles, and part of the bladder neck. Not a common surgery. There's different ways to approach this, which are on the next slide. This patient will have a Foley and possibly a suprapubic catheter. That's just a catheter that has been inserted through the abdominal wall directly into the bladder. This patient can have a lot of issues post-operatively, including impotence and urinary incontinence. Because of this, there is a newer procedure where physicians try to do what we call a nerve-sparing procedure, so younger men will not have these issues. In addition to taking the gland, the vesicles, the bladder neck, they also go in and do what we call a retroperitoneal lymph node dissection. And this is mainly done to check the lymph nodes to see how many are positive for cancer cells, and this will help guide the physician in the treatment post-op. This just shows some of the different approaches to having a radical prostatectomy. On your left, it's showing you, okay, here is the bladder, and here's the prostate, and here's the urethra. And then right next to it, it's saying, okay, we've taken the prostate out, so what we've had to do now is reconnect the urethra to the actual bladder. We can do this what we call retropubic, which is the more common, where we have a low horizontal incision. There is also a perineal approach, where the patient has an incision between the scrotum and the anus, and then what we call suprapubic approach, where they have a vertical midline incision. This is also commonly being done laparoscopically now, where the patient would just have several lap sites, typically 4 to 5, about 1 inch long. And there is also the robotic approach, and there's even fewer incision sites with the robotic approach. Most prostate cancers are slow growing, and because of that, we look to just delay tumor growth, prevent metastasis, preserve the quality of life. Your book tells us that prostate cancer, when diagnosed in the early stages, that the 5-year survival rate is 100%. And so therefore, a lot of times, we do what we call active surveillance. We know that most prostate cancers are relatively slow growing, and therefore we just watch and do not treat. And some guidelines would be, for instance, if their life expectancy is less than 10 years, they have significant comorbidities, and it is a slow-growing, low-grade, low-stage tumor. The most common treatment is radiation therapy, and the most common of those is the external beam radiation therapy, typically delivered like 5 days a week for 4 to 8 weeks. We deliver radiation to the prostate area. It is useful when the prostate cancer is confined to the prostate or just the surrounding tissue. Some of the side effects can include changes to the skin, so we need to monitor the skin in the area. The GI tract is there, and so we've got to watch for issues on the colon, diarrhea, cramping, abdominal pain, urinary tract infections, also impossible sexual dysfunction such as ED. Might also have a systemic side effect such as fatigue. Brachytherapy for prostate cancer actually delivers a more precise amount of radiation specifically to the prostate gland. There is an actual picture on the next slide, but these radioactive seeds are actually implanted into the prostate gland under the guidance of a transrectal ultrasound, and therefore a more precise radiation therapy is delivered to the prostate gland and spares the surrounding tissue, so you don't have as much tissue damage. So for instance, the patient wouldn't suffer maybe as many GI effects, and hopefully would only suffer maybe some urinary side effects. And so we'll look at the next slide. As you can see here, under the guidance of an ultrasound, the seeds are actually placed into the prostate tissue, and these seeds deliver a radiation and hopefully help to eradicate or shrink the tumor. The seeds can be multiple in numbers. It just that's dependent upon what the patient needs. No seeds are actually left in the patient. Sometimes there are actual catheters that are left in the patient, and they can use these catheters repeatedly to deliver the seeds, but once this treatment is over, the catheters are removed also. Okay, so if you're following along in your book, we're on page 1319, and it talks about how often one of the first approaches to treating prostate cancer is to put the patient on hormonal therapy, or what we would call androgen deprivation therapy. Depleting the level of androgen helps to actually reduce the size of the prostate or reduce the tumor growth. And it can be used in conjunction with surgery or radiation therapy. One of the issues with this particular type of treatment is the tumors do become resistant to the therapy, and this is monitored by PSA levels. Okay, if you guys are on page 1319 and look at the drug therapy box on the bottom of this page, go ahead and get your highlighters, and we'll talk just about a few of the drugs on the bottom of this page. So the what we call the LHRH agonist, the one that's popular is leuproride, and eventually what it does is it does decrease testosterone production. Your book talks about the fact that often these drugs, when started, cause a flare, temporarily increase testosterone, and might make symptoms worse for the prostate cancer, but eventually does decrease testosterone production, helps to shrink the tumor. Side effects: hot flashes, gynecomastia, decreased libido, ED, could cause depression and mood changes. We skip down to the CYP17 enzyme inhibitors, and the abiraterone actually also decreases the production of testosterone. The signs and symptoms are very similar to the LHRH agonist, to include, though, joint swelling and fluid retention. And then you get down to the bottom of the page, the androgen receptor blockers, the Casodex, actually blocks the action of testosterone. So the levels are the same, but it blocks what it's supposed to do. And you see once again that your side effects are very similar. You can read through the chemotherapy, primarily limited treatment. The goal is palliation, and palliation just means that we're trying to manage the signs and symptoms that the patient has of the cancer. And so the goal is palliation, as the prostate cancer really does not respond very well to chemo. These are some of the more common nursing diagnoses for prostate cancer. Decisional conflict, meaning the patient has to make a choice as far as the treatment options that were presented and which treatment option best suits them, and then you can read through the rest. So as far as health promotion for someone who is experiencing prostate cancer, really health promotion would be that we as nurses encourage men 50 years and older to get their annual PSA and DREs. And as we said previously, if someone has a positive family history or is African American, then we would encourage them to start sooner. As far as acute interventions, this would be taking care of someone before and after surgery, whether it would be that they've just had a biopsy or whether they've had a radical prostatectomy. Our goals are very similar to those caring for someone who's had BPH surgery. We just would want to make sure that they had adequate urinary output. We're measuring it, watching for peritonitis, which is an inflammation or infection of the peritoneal cavity. So watching for signs and symptoms of infection, monitoring for bleeding, if they have a folian, watching the color of the urine output and watching for clots, and also making sure that the patient understands what we're watching for, and making sure that the bladder irrigation or the Foley catheter stays patent, that if we need to, we're irrigating or flushing the catheter as needed. Additional acute nursing interventions would be to monitor the PSA levels. They often tell us how therapy is going. If a catheter is left in, teaching the patient how to clean around the catheter with soap and water, and monitoring for signs of infection. We've already talked about discussing, as with someone who had BPH and a catheter was left in or had BPH surgery, how there's the issue of possible incontinence and impotency, and discussing these issues with the patient. If they do develop metastasis, then often there is a decision to be made between hospice versus palliative care, and monitoring and treating pain. once they're going to go home, what do we need to make sure that they know in order to take care of themselves properly? So, no strenuous activity or heavy lifting for 4 to 8 weeks, generally no driving for 2 weeks. As we said, watch for bleeding. It's not uncommon after having a bowel movement or coughing, but if they notice blood in the urine, then tell them to increase their fluids and rest, and this should clear it up. And if it doesn't, then they need to call their physician. Post-op, no NSAIDs or aspirin for 2 weeks. This increases the risk of bleeding. They need to resume their diet, drink lots of fluids, avoid alcohol, typically no sex 6 weeks after surgery, and that they may experience some burning or incontinence or leakage after surgery, and we need to make sure that we can instruct them on how to effectively do their Kegels.